So I'd like to thank Tatiana for asking me to talk about tics. This is a topic I continue to be very interested in, but I haven't given a lecture on tics for maybe 5 or 6 years now. So it was a good opportunity to update myself on the literature and find out what's happened. So Gilles de la Tourette syndrome, at least in English, this sounds like a beautiful name. So it's a beautiful name for a very unpleasant disease. At least the disorder has got a nice name. Where is the slide? Oh, here, I got it, yeah. So you already saw on the poster that my book was translated into Russian, and much to my surprise, it became a kind of blockbusting hit. Because in England, the book was not very well read, but in Russia and in Ukraine, many people bought this book and continue to use it, which I'm very flattered about. So when I was a medical student, I read a book called Uncommon Psychiatric Syndromes. And in this book were things like Cotard's syndrome, de Clérambault syndrome, Othello syndrome, all neuropsychiatric conditions with very exotic names. And amongst those were Gilles de la Tourette syndrome. And as a medical student, this particularly attracted me because I remembered that one of the features of Gilles de la Tourette syndrome was coprolalia. So this is the first thing most people remember when they think about Gilles de la Tourette syndrome, even though only a very small proportion of patients with this syndrome have copro phenomena. So I think that's why it stuck in my mind. So when I became a resident, a neurology resident, I decided to study tics. So I went to see the chairman of the neurology department at the National Hospital in London where I work, and he said to me, "Lise, if you study tics, you cannot become a neurologist. This is not a respectable topic for a neurologist to study, because this is a very rare psychiatric syndrome, and it has nothing to do with neurology. And in any case, we don't want to have these noisy, disruptive patients coming to the little hospital where I worked." So I didn't get much encouragement. And then not long after that, the Shapiros, who were two psychiatrists working in New York, published a very big Teutonic book on Gilles de la Tourette syndrome, in which they argued that it was a disorder of the basal ganglia, identical to, for example, chorea or Parkinson's disease. So they took, although they were psychiatrists, they took a very organic position in thinking about tics. So at that time, I suppose this book encouraged me to study tics. And we started to look for patients with Gilles de la Tourette syndrome. This was in 1980, when the condition was hardly known in England. So if you walk down the street and you asked people in the street, "Do you know what Tourette syndrome is?" Nobody had ever heard of it. It was so unusual and so rare. And the patients who had been diagnosed with the condition were often assumed to be psychotic. So there was a misconception about what this condition was in 1980. So I was desperate to find these patients. So we put an advertisement in the newspapers. Do you have tics? Do you make abnormal noises? And we managed to collect about 30 patients, and we published them in the Journal of Neurology, Neurosurgery and Psychiatry. And out of that publication came this book, which was introduced by MacDonald Critchley, who was one of my teachers, and some of you may know him. He was the president of the World Federation of Neurology. So what are tics? Well, they're fragments of motor behavior. So they don't look, and one can start to discuss, are they abnormal involuntary movements? Are they abnormal voluntary movements? Are they normal involuntary movements like hiccups or a sneeze? Or are they normal voluntary movements like doing this? Now, the Shapiros and many neurologists have called them abnormal involuntary movements, but they're not completely involuntary. As you all know, they can be partially suppressed by willpower. So I like to think of them more as abnormal semi-voluntary movements. And they are exaggerated. They occur in inappropriate space and time. They're often stereotyped. They're often very rapid, but some of them are more tonic and gradual. But when you look at somebody with tics, the movements don't really look abnormal. They look like, many of them look like gestures, normal social behavior gestures, but they're occurring in an inappropriate context. So they're not occurring in the right situation. So they can be confused with myoclonus because they're usually very rapid, but they're really different. And myoclonus is completely involuntary. It's impossible to suppress myoclonic movements. So sometimes I like to, when I'm teaching the students, I like to say that tics are a little bit like sneezing, so that if you try to suppress a sneeze, you can manage to do it, but it builds up a feeling of tension inside, which is only relieved when you sneeze, and then the relief happens. So the other thing that helps you to recognize tics is that they're quite easy to imitate. So Mary Robertson, one of my colleagues in London, is an expert at imitating tics. So they're much easier to imitate than chorea or myoclonus. And this is because they are actually fragments of normal motor behavior. Now, the other thing which often helps you to recognize tics and to distinguish them from abnormal involuntary movements is the predilection for the head, the neck, and the face. So most tics occur in the face, because it's the face, of course, which is responsible for most of our body language and our kinesics, and also in the head. So they're much less common in the limbs. So this can be another helpful distinguishing feature from other movement disorders. Now, I've already mentioned that tics fluctuate markedly. They fluctuate much more markedly than any other abnormal movement disorder. So they fluctuate in over seconds. They're very situation specific, much more situation specific than any of the other abnormal movement disorders. And they have specific triggers, but sometimes the triggers are very difficult to identify in an individual patient. So this is a slide from Leckman's work showing that tics can fluctuate over days. Some days the patient has hardly any tics, other days they have terrible tics, and they can also fluctuate over hours, minutes, and seconds. And those of you who have looked after patients with tics will also know that some patients get what we call status attacks of tics. So these are attacks of tics that can go on for several hours, very severe, often triggered by anxiety, and then they disappear again. So the space and time thing is quite important. Now, another thing which is very important in tics is that some patients, not all, recognize an impulse or an urge or a feeling which precedes the movement. And many tic experts say that it is the sensation or the feeling which is involuntary, not the movement itself. Now, not all patients have this, but some do. And it's said that those patients who have greater awareness of the subjective urge which precedes the movement are the ones which have a better chance to control their tics. Now, I'm not sure that this is completely correct, because there are many patients who are not aware of subjective urges, but can still suppress their tics. So there seems to be a disparity in some patients between the recognition of the urge and the ability to suppress the tic. But recognition of the urge is very important in one of the main treatments of tics, which is behavioral or comprehensive behavioral therapy with habit reversal. Now, what you see on this slide from Leckman's work is that the distribution of the urges is not the same as the distribution of the tics. So that if you ask patients with Tourette syndrome where they feel these strange feelings, they're quite commonly in areas of the body which do not tic so much. So there is not a very close correlation between the positioning of the urge and the motor tic. And what is interesting, this is work from Ganos and Alex Munchau in Germany, in Hamburg. You find that the urges where tics are not very frequent are the ones which are most useful in inhibiting tics. So if you have an urge in the pelvis and a pelvic tic, you are more likely to be able to suppress it with the urge in the pelvis than you are in the much more frequent eye position. So eye blinks are the commonest tic, and they are the most difficult tics to suppress with urges. So behavioral therapists have a lot of difficulty getting rid of eye wink tics. So this again shows that there is some difference between the tic inhibitory potential and the percentage of tic counts across body parts. Now, just to tell you a little bit about Gilles de la Tourette, who was one of Charcot's disciples, one of his most sycophantic disciples, and the one who transcribed all Charcot's Leçons du Mardi. This is Gilles de la Tourette, Joseph Babansky, Pierre-Marie. So these were the stellar disciples of Charcot. And at the time Charcot was practicing, the classification of choreas was chaotic. So he asked Gilles de la Tourette to help classify better the chaos of the choreas. And Gilles de la Tourette translated from English a paper called The Jumping Frenchman of Maine, which was published by George Beard. And he argued that if jumping Frenchmen existed, they should exist in Paris as well as in Maine, in the French-Canadian border. So he started to look for jumping Frenchmen in Paris. as part of his classification of the careers. And he didn't find any, but he found something quite similar, which he called the maladie des tics convulsifs. And like Parkinson's disease, it was Charcot who bestowed eponymous fame on him and called this new condition Gilles de la Tourette syndrome. Gilles de la Tourette is also interesting because he became the subject of a very celebrated medico-legal case in Paris at the end of the 19th century, where there was a controversy as to whether patients could be hypnotized to do things against their will, against volition. So that, for example, you could hypnotize a hysteric and they would do things under the command of the hypnotherapist. And this lady shot Gilles de la Tourette in his consulting room. He survived. He had a bullet in his neck. And it was claimed by her lawyers that she had shot him because he had hypnotized her and made her do this. In fact, the case was lost, and she was committed to a mental asylum, and he survived. But he didn't survive much longer because at the age of 49, he was taken by his friend Charcot's son to a sanatorium in Switzerland. And those of you at the front will be able to see the diagnosis when he died at 49, which was PG, paralysis generale, neurosyphilis. So he died at the age of 49 of neurosyphilis. So that's a little bit about him. What did he describe? Well, the division between tics and Gilles de la Tourette syndrome is completely arbitrary. Biologically, they're the same thing. But provided you have one motor and one vocal tic or more, and that you've had them for more than 1 year, you can say that the diagnosis is Gilles de la Tourette syndrome, even if it's very mild. Often is very mild. The prevalence is different from different studies, but it's said that up to 1 in 200 children at least have Tourette syndrome, which is quite common. I mean, it's certainly not the rare disease that I learned about as a medical student. And what is quite interesting is that in childhood, there are 3 to 4 boys to every girl, but by the time, if the tics do not disappear, by the time you get to adult life, the sex ratio is only 2 to 1. So women become relatively more common. And everybody generally believes now that it's genetically determined, although no genes have yet been clearly identified, that it's a neurodevelopment disorder. And obviously, because of the male predisposition, you have to think about neuroendocrine influences on behavioral development as well. Now, this is the important thing to remember about Gilles de la Tourette syndrome is that it's really very different from the abnormal involuntary movements that the Movement Disorder Society is mainly interested in. This is a very complex neuropsychiatric syndrome, and we don't even really fully understand the phenotype. Exactly what is the phenotype, which is why the geneticist may have had some difficulty in it, despite spending millions of dollars on genetic research, have still not found key candidate genes. So only about 1 in 6 patients with Gilles de la Tourette syndrome have a pure tic disorder. The large majority have these other overlapping syndromes, obsessional compulsive behavior, and attention deficit disorder, hyperactivity syndrome. These are very commonly linked with Tourette syndrome, and even some forms of autism and Asperger's syndrome also seem to overlap with tic disorder. And these problems lead, of course, to depression, anxiety, lower quality of life, and an increased risk of premature death. So this is not a medical curiosity. It's a very serious condition worthy of the attention of neurologists. So a few words about obsession. The obsessional compulsive behavior in Tourette syndrome is a little bit different from that you see in primary obsessive compulsive disorder, which is a disease which is commoner in women than men, and fears of contamination, which is a very common presentation of obsessional compulsive disorder, is very rare in Tourette syndrome. What Tourette syndrome patients like to do is match things. They have obsessions of symmetry, they have obsessions of calculation, they sometimes have folie du doute, doubting behavior. And the idea that there was a link between obsessional compulsive disorder and tics is not new at all. The early neuropsychiatrists, Charcot's disciples, all of them raised the possibility that tics may be a degraded fragment of compulsive movement. And you remember what Sigmund Freud said about obsessions, that these were repressed and of sexual and aggressive urges, and I want to come back to that when I show you some examples of super Tourette's. So obsession and tics are in some way interlinked. So from being a disorder that was associated with psychosis, in
what he was making.
Yeah,
was a cheap, easy joke. Biscuit, the Biscuit he has described and sort of described as off the cuff, but really Biscuit reveals an attitude towards Biscuit, towards disability, and towards people, and towards the impacts of.
I'll tell you what this is about.
Of sort of language and the language that you use on about disability that I think is.
Can you play the top one as well? The top.
Unhelpful.
Clearly, he's getting right under
the one at the top.
Yeah. And this is what they told the Sunday Telegraph about the Shadow Chancellor. He said, he just annoys me, Mr. Cameron said, but I'm very bad in the House of Commons at not getting distracted, and the endless, ceaseless banter. It's like having someone with Tourette's permanently sitting opposite you. Now, clearly.
So, of course, this illness brings a great stigma, and what that radio commentary was about was that in the Houses of Parliament in England, David Cameron, our previous Prime Minister, one of our previous Prime Minister, was complaining that the opposition bench were moving and talking all the time, and that it was like sitting next to an individual who had Tourette syndrome. So, of course, the Tourette tribe became very upset about this because it was adding to the stigma of the disease. So the Prime Minister had used it in a derogatory way to describe restlessness and continuous interruptions with vocalizations. So there's a stigma, but for a short period of time do you have Big Brother in Ukraine? No. Do you have the television program called Big Brother? Maybe some of you have heard of it. Big Brother. You put people in a house, and they have to stay in a house, and you watch the social interactions, and it's a very big television program in England and in many other countries. So about 15 years ago, this man, Phil Bennett, who had Tourette syndrome, was the winner of the Big Brother celebrity competition in England. So from being a stigmatized disease, for a short period of time, it became very fashionable. So some young people were almost imitating Tourette's because it was kind of hip and fashionable to be Tourette. this soon disappeared, and again, it became a stigmatized disease. But just for a little while, it became quite fashionable to have some tics. Now, of course, I mentioned at the beginning that the basal ganglia has always been of interest in the pathogenesis and the generation of the tic-like movement. And of course, we know that dopamine antagonist drugs can reduce the severity of tics, again, providing indirect evidence to suggest that the dopamine systems might be involved in the pathogenesis of tics. But clearly, there is much more to tics than just the basal ganglia. And people have talked about the cortico-striato-thalamic circuits as being very important. There is some interest in what's called a social decision-making circuit, which involves the periaqueductal gray matter, the amygdala, and the hypothalamus, and that this might also be damaged or dysfunctional in people with Tourette's. And of course, the abnormal behaviors that you see in super Tourette patients resemble the limbic brain. They're almost like a Kluver-Bucy syndrome. And this is another of our prime ministers, Margaret Thatcher. What she's trying to do is the Winston Churchill victory V sign, but she has a dyspraxia, so she's doing this very bad copromimic sign, which is like this sign, you know. I don't know what you do in Ukraine, but you know, it's like this. It's a bad sign, as you can see from this skinhead. So she's making a mistake. And you can see watching her is Lord Owen, who was very involved in the disputes in Yugoslavia, the former Yugoslavia. And interestingly, he trained as a neurologist before he became a politician. So he's watching her and saying, what's she doing? She got it wrong. So this video is just to show you the interaction of patients with Tourette's. This is one of my patients who they made a television documentary of. He had been considered to be psychotic when he was a young man, but he's adapted reasonably well. And what I want to show you in this video is how quick-witted and how
hello, I'm Heather from Citizens Advice Bureau in Galashiels.
So you'll see several Tourette.
Fuck off, nosy. Absolutely. And we sound as
so this lady is trying to give them advice. It's quite difficult, as you'll see.
Chopper dyed his pubes ginger.
Through the list. This person would be expected to tolerate the behaviour.
Fuck off!
Quite. That's not a very good wording for it. But there is somebody who's actually
your dogs get tits
in the law and thought it through at last. And I'll leave that with you so that you can have a look at it.
You're very helpful.
Then there's more on. Did you mean it or not? That's the dealing with it. So I'll leave. That's how the points work now, and they are better than the old points. Everyone on incapacity benefit is going to be moved on.
You've got Tourette's by proxy now.
15 points for speech can't be understood by strangers. Absolutely. You get 9 points for strangers have great difficulty understanding speech.
Pakistanis and Iraqis.
You get...
I get stabby with knives.
Yeah.
In the kitchen. Somebody's walking past.
It's a really difficult call, though. But it's arguable that benefits-wise, you should be getting the maximum benefits because at any given moment you might need a minder. But you might not...
Arthur Daly!
Quite right. But
so we can stop it, but... So you can see that, first of all, you can see that tics are infectious. They feed off one another. And this lady is doing remarkably well. I don't know if any of you have ever spoken to a group of people with Tourette syndrome, but it can destroy people. I mean, I've seen scientists talking to groups of Tourette patients in tears, because while you're talking, you're getting that, you know, and it's, if you're not ready for it, it can be really quite destructive. And this is, of course, why there is an enormous stigma. These people can't go to the cinema, they can't go to the theatre, all these sorts of things. But at the same time, they're incredibly quick. They seem to have super reactions. And some of them, as I'll tell you later, are really quite creative. So I've told you about Freud and his links between aggression and sexuality and obsession. Now, in the severe Tourette patients, what you can see are emblematic displays of aggression and sexuality. You can see the body language of anxiety, you know, the fidgety, restless. You can see matching and symmetry compulsions and echo phenomena. And you can see a particular type of self-injurious behavior, neck jerks, body punching, and head banging. And some of these movements, as I've already said, are very primitive Darwin-like facial expressions. So the expressions that the Tourette patients make are quite similar to some of the emblems that Jane Goodin, who studied chimpanzees for years, characterized. And this is George Bush, it's a kind of funny thing just to show you that humans and monkeys with primitive language, body language, can be quite similar. So this is a 4-minute clip, and I want you to look at the emblematic displays of these super Tourette patients. So these are the very severe cases.
Right. What movements do you have? Can you tell us?
Right.
Right. Do these movements disturb you at all?
Well, I do, yeah.
You do, right. Can you tell us how old were you when these movements started?
15, well, when I first calmed down, 15, I was thinking good. I was very short.
Right, okay. Right.
Lots of coprolalia.
Tell me, can you stop all these movements if you want to? Even for a little while?
Sometimes I can. Harder.
So this is a girl with exhibitionism. The camera, she doesn't know that she's being filmed. It's a two-way camera. So she thinks there's nobody there.
I go swimming.
Debilitating. How do you find
this man is like something out of Hannibal Lecter. I mean, he's got to have this mask on because as soon as it comes off, he can't stop spitting.
Tell me if it's uncomfortable, we can put it straight back on.
Uncomfortable? That's right.
You're all right?
As long as you're all right.
Yes, I'm fine. How do you find people's reaction to you, particularly in public? Unwanted.
You've got a mic at some point.
Yes, I can.
No, I don't get any thoughts. Unwanted, no.
Look, one moment.
Come on! Send him in his track,
So he has to keep this, it's a shocking case, really. I mean, he has to keep this mask on. And this is another fellow who you'll see.
I'd like to be able to sit with these people.
He's kind of very restless, very anxious.
I can't protect myself in a fight because ticking like this I have very little control over, especially when I'm anxious. And
so he bites himself. You can see he's biting his knee.
Anxious.
That's one of the other things that you have to do.
To bite myself. It's like all of these movements make me feel a certain way. To type, I find that the tics almost like travel through my fingers. Fuck off.
He feels the tick travelling through his fingers. So now he's biting his shoe.
Sorry.
He keeps destroying all his shoes.
Not very pleasant, but it has to be done. And by ticking through my fingers,
he's smelling his shoes.
It makes me regain some balance.
Fuck off then, you nutter. Why? Slag. You! Fuck off, you bastard. Fucking bitch. Oh! Woo! Bollocks. Durex for the life. See, I even use brand names.
So he's got long strings of interesting corporal phenomena.
Liquidized lumps, yeah. What a bloody mess. Fucking one more.
So he emigrated to America and he went to see Oliver Sacks, who was very interested in seeing him and wrote back to me about him. So just remembering those videos, and then this is a very interesting description by Kaplan, a psychiatrist, in 1899, the neurology of anger, or the neurology of rage. Following the most trivial and impersonal causes, there is the effect of rage with its motor accompaniments. They may be the most grotesque gesticulations, excessive movements of the face, and a sharp explosiveness of speech. So coprolalia is often delivered in a very aggressive way. So the sound of the voice is very aggressive. There will be cursing, that's swearing, and outbreaks of violence, which are often detected towards things. So the neurology that's linked with anger, episodic discontrol, explosive anger, sometimes resembles some of the motor behaviors that we see in severe tic syndromes. So this may be giving us another clue as to what's happening. Now, what do we know about the pathology of Tourette syndrome? Virtually nothing. So in 1957, based on a single post-mortem study, Klaus and Balthasar in Germany developed the concept of striatal dwarfism or hypoplasia of the striatal nerve cells as a developmental consequence and cause of Tourette syndrome. So this was one of the early suggestions that this might be a basal ganglia problem. And then much more recently, but still not confirmed, it's just a single case study, it's not been confirmed by a different group. There's some suggestion that there are changes in the pallidum at histology with a decreased number of GABA parvalbumin staining cells, with a decrease in the striatum and an increase in the pallidum, and some changes of cholinergic interneurons. So we know very little about the pathology of Tourette syndrome. These are the only data that we have. So like genetics, we're really lacking anything very solid or substantial to hold on to. Now, there are some patients who develop Tourette syndrome after the age of 21, and we wrote some of these patients up. We call them adult onset tic disorders or adult onset Gilles de la Tourette syndrome, so that they do not fulfill the rigid diagnostic criteria. And what was common in these patients was that some of them had had post-traumatic stress before the onset of the tics, and others had had injuries, traumatic injuries. So there seemed to be some triggers for these late onset Tourette syndrome. So I don't know if we can just show this video clip. This is one of these patients in this. If we can press the video, if it works, it's right at the bottom. No, not working very well. Well, it doesn't matter. I mean, so she's a lady who makes loud noises, and she developed these tics following post-traumatic stress in her 30s and 40s. So there is a rare group of patients who can get similar problems later in life. Okay, we can just show her now.
Instead. I hit them.
So as a child, she was normal, no tics, no obsessive compulsive problems. So although it's rare, you can get late onset Tourette syndrome. Okay, so some of you may be familiar with this. A few years ago, there was an outbreak of what was called mass hysteria in an American city where many young women developed abnormal movements. So can we show the clip? So they called it mass psychogenic illness.
Lydia Parker is experiencing the strange symptoms. Her right arm continually jabs the air.
I can't stand for more than about 2 minutes, so I'm in a wheelchair, and my vocal and tic, everything gets really bad at night.
The doctor who's treated most of the teenagers believes this is a form of mass psychogenic illness, a rare disorder often called mass hysteria.
I personally have never seen anything like this before. It is very, very remarkable.
Enter the famed environmental activist Erin Brockovich, once portrayed by the actress Julia Roberts. Ms. Brockovich wants to know whether a toxic chemical spill back in 1970, which happened 3 miles from the future high school,
so that was the school. All the victims came from the same school.
There are other people coming out reporting that they lived close to the spill site, that their family is experiencing health problems.
Members of Erin Brockovich's team visited this rural community. They want to know whether...
So this is what happens when famous people get involved with clusters of disease. So Erin Brockovich was suggesting that this was all caused by a toxin in a toxic waste close to the school where these children had all been affected with these strange movements. Now, most of the neurologists who saw these girls felt that these were not tics, they were pseudo-tics, so that they were completely volitional, they looked different. And I think what's happened is most of them have recovered. Some have been left with psychological problems, but the abnormal movements have disappeared. Now, there is a way neurophysiologically of trying to distinguish psychogenic tics from tics. But this relies on the patient having a fairly frequent stereotype tic so that you can back average and record a large number of movements. So if you have psychogenic tics, you have an early Bereitschaft potential here, whereas in most patients with tics, you either have no Bereitschaft potential or a late Bereitschaft potential. And in cases of myoclonus, you have no Bereitschaft potential at all. So through neurophysiology, it might be possible to distinguish in some patients psychogenic tics from ordinary tics. And this is also quite important because some patients with tic disorders embellish their disorder with psychogenic tics. So some of the status tics that patients with tic disorders have maybe psychogenic, mixed, like epilepsy. You know, some patients with epilepsy can have pseudo-seizures as well as genuine seizures. So this may be a helpful way of distinguishing. Now, I've learned most about tics, as I have in most of medicine, from listening to what people with the disease say about their disorder, because that's how we learn in medicine. We listen and we learn. And I think this description by Peter Hollenbeck is a very good description of what it's like to have Tourette syndrome. So I'll read it to you very quickly. I finally apprehend the magnitude of the background noise that I have been experiencing for decades. The people around me do not share my tics because they do not hear the drumbeat. They do not feel the sensations without sources, do not have irresistible urges to pause in mid-sentence, do not receive strict internal commands to trace with their eyes in mid-air the shape of each of Aristotle's regular solids, and so on in endless, bewildering variety. Finally, and most important, I feel convinced that this complex, challenging, enigmatic internal world is the core and essence of Tourette syndrome. So this has led to ideas such as this suggestion by Alex Munchow and Ganos, the theory of event coding, so that there is misplaced learning. That Tourette's is a kind of learning disorder leading to inappropriate habit formation. And it's due to a binding between external stimuli, for example, the urge, here, which is a perceptual sensation, leading to an action, and then a feedback back to the urge. And this you can use to explain echo and copro phenomena too. And of course, the movements lead to all these problems, so that if you pay attention to a tic, it'll make it worse. If you distract the patient from the tics disappear. So behavioral therapy is designed to try to draw patients away from the habit of thinking about ticking to something else. And one of the characteristic features of tics is that if the individual is involved in something that they like doing, and it involves and requires attention, the tics temporarily disappear. They go away, and then they come back again. And I just wanted to, of course, I've told you a lot about the morbidity of tic disorders and how devastating it can be on quality of life. But there may also be a positive side, and one of the great achievements of my friend Oliver Sacks was that he emphasized the positive of neurological disorders, so that he tried to tell sufferers with these diseases and everybody, the world, that although these people had deficits, they often had gifts too. And one of the gifts that people with Tourette syndrome may have is that because they're very fast, they may be good sportsmen, and they may also be creative in the arts, such as in music. And this is another patient, a jazz drummer. Rhythm and Tourette syndrome has been intertwined from the first day I found drumming on a table could mask my jerky hand, leg, and neck movements. So he realized that when he was drumming, he could get rid of his tics, and that the drumming would discharge the excess energy in a more appropriate direction. So every impact of the stick became a feedback signal, and my hands learned very quickly how to make the sticks dance. I also began to associate sounds with movement patterns, which is I think this is very interesting. I also began to associate sounds with movement patterns. So if we could, this is a patient of mine who is a concert pianist. So he's And he plays, so yeah, let's play the video. So he's called Nick Bloss.
I want to stick my fingers in the sandwiches. It's a wash. I'm almost dizzy and spinning. I want to spit in the waiter behind the bar's eye. It's like something's inside of me making me do things I don't want to do.
And then the other video. So he's able now to control his tics sufficiently through behavioral therapy to play in concerts, good big concerts. And he links very closely his tic disorder with his musical appreciation. And when I was in the United States, this is a long time ago, I had the fortune to go to one of the Tourette chapters where they were doing what are called drum circles. So they were using music as a kind of therapy to channel energy in patients with Tourette's. And so they were all doing this. So if we could play it a bit louder. He was the star, of course, but around the room they had all these pipes like this, and all the Tourette patients were hitting them, and they found it very therapeutic and helpful. So music as a sort of creative therapy. And then, but when they're not playing the music or when they're not singing, there is something very interesting. This is a very interesting paper by Alexander Munchau, who was at the concert hall in Hamburg, listening to a Bach choir, and he noticed that when the boys were not singing, when they were not actually singing, between singing, 35%, 14 of the boys in the choir had tics. So, you know, this is a very high figure. So he and two colleagues counted all the tics in all the boys. So it maybe, again, suggests that there might be a link between musical creativity and tic disorder in children. Now, this is another rare variety of tics, which brings Gilles de la Tourette's Jumping Frenchman together with Maladie des tics convulsives, Gilles de la Tourette syndrome. So there are a few patients who startle or surprise generates tics. So these tics are distinct. We've called them reflex tics. You don't see a Bereitschaft potential before the movement, and then the patient has a tic, but it's triggered by a startle. And Marina Tyson, who worked with us at Queen Square, who is very interested in hyperplasia and startle disease, went to Indonesia to study a culturally related startle syndrome called LATA. So probably many of you know about these. In Russia, there is another condition called Myriashit in Siberia and in some other parts of Russia. And these are culturally related startle syndromes, usually in remote areas. So I just wanted to show you a video of LATA, where the startle is often increased. The startle response is significantly increased in these patients. But instead of just having a startle, they have this culturally exaggerated response. So if we could show the video. So you can see they have a lot of echo phenomena, startle, but it looks different. It's a bit different from Gilles de la Tourette syndrome. It shouldn't be considered the same, but you should look out for these interesting neuropsychiatric disorders in Ukraine. There are probably some others still to be discovered, because when I went to Istanbul, I saw this man who works in the Grand Mosque, in the Grand Bazaar in Istanbul. And the doctor who had seen him took me to see him. And I'll tell you, the video is playing, so I'll tell you when it's finished. So you see he has automatic obedience. And the doctor has told him, please do not copy what I'm doing. You must not copy what I'm doing. But he still does. So this condition in Turkey, I don't know if I'm saying it right, is called Huylu, Huylu. So some of the Turkish anthropologists know about this condition. And we wrote this case up in Movement Disorders in 2012. So this man, it's an interesting story. It came on, he was bitten by a mouse. And this problem, according to him, when he was a child, he was bitten by a mouse. And this problem, so he's imitating people on the television now as well. So a rich man who has a carpet shop in the Grand Bazaar in Istanbul, probably some of you have been there, employs him to serve apple tea. And he also, I mean, his behavior is encouraged as a kind of entertainment for visitors to the to the bazaar. So he's kind of found a way of making a living now from it. So that will probably make it more difficult to treat him. So just to finish, a few words about treatment. I think all of you know that the natural history of tics is quite good. The majority of children with acute single tics will lose the tics as they get older and get out of teenage years. So it's quite, you need to be quite reassuring in the majority of cases to parents with a child, a little boy with one tic. But sometimes the tics are more severe, and occasionally treatment is needed even in childhood. So there are different sorts of behavioral therapy, comprehensive behavioral intervention with habit reversal, which is teaching children to pay attention to the urge and then try to suppress the tic and replace it with a more socially acceptable motor habit, and then rewarding for managing to do it. So the behavioral therapists usually start by concentrating on just one tic, try to get rid of the eye blink. If they get rid of the eye blink, they then try to get rid of another tic. So 20 years ago, most people were talking about drug treatment for tics and Tourette syndrome, but because of the realization that particularly neuroleptic drugs have so many side effects, patients don't like them, they're only partially effective, the first line of treatment really now for most patients is behavioral therapy. You may sometimes need to use a dopamine antagonist drug such as haloperidol or pimozide, but mostly people, especially with children, try to avoid using neuroleptic drugs. And also, I mean, in my experience, the noradrenergic drugs, clonidine and so on, are not very much good. I mean, I've not had much success with those drugs. A newer approach is to mindfulness is popular for all psychiatric illnesses, but there's been some success in reducing stress with mindfulness in individuals with Tourette syndrome. This is still a pilot study, but it's showing some interest. And some of you may be keen on transcranial motor stimulation. If you stimulate the supplementary motor cortex, you can temporarily, and the important thing to mention is temporarily, reduce tics. So it doesn't seem to carry over, but at least TMS can temporarily help tics. Now, I thought I'd just tell you about a new trial. There is some anecdotal evidence from patients that cannabis and marijuana can help Tourette syndrome. So at the University of Lübeck in Germany, they have ethical consent now to do a double-blind trial using Sativex, which is the medical marijuana, which is licensed for the treatment of pain in multiple sclerosis, to look to see if this will help patients with Tourette's. And then a few words about surgery for the very, very severe cases, adult Tourette patients, very severe, that cannot be helped by any other treatment. When I was writing my book on Tourette's, one of my patients had a limbic leucotomy, which was making lesions in the anterior cingulate cortex, and it was very successful. So he had 1 centimeter diameter lesions in the inferior cingulate gyrus and the anterior hypothalamus, and before surgery on PET scanning, you can see that there was caudate hyperactivity, and then after the lesion, this disappeared, and his urge to break windows, destroy clothes, self-harm, and coprolalia all improved substantially for more than 2 or 3 years. And then more recently, of course, there has been, in the last 10 years, interest in deep brain stimulation in Gilles de la Tourette syndrome. Again, I emphasize the most severe cases are the only ones that should be even considered for this. And we don't really know where to put the lesion. So all the different surgeries have all been in different places, and you could add the amygdala to this list of possible stimulation sites that might be interesting. So there are 39 articles of 100 patients with 9 targets, and success has varied from clinical benefit, reducing tics on the Yale scale by more than 96% in an individual patient, to less good results. So the data is very difficult to interpret, and the duration of follow-up is quite short. At Queen Square, we have been using the pallidum, using the globus pallidus internal segment stimulation, and we published our results on a few patients a few years ago. Some of the results are good. If I can just show you these 2 video clips. So this is the patient before surgery. Very severely handicapped. He never left his house. Couldn't go out, couldn't work. He tried all the drugs, psychotherapy, behavioral therapy. Nothing had helped him. He was desperate, and he threatened to commit suicide. Okay, we could show the second one now. I mean, of course, it's easy to fabricate these videos because Tourette's comes and goes. You know, I could show you anything. I could make it up because it varies so much from minute to minute. But the results were pretty good with him, and he was pleased that he'd had surgery. Still got some tics. This is another boy who we reluctantly operated on. You'll see the video of him soon, but he was having movements like this, so that you can see on the MRI all these little non-compressive myelopathy changes with posterior cord lesions. You can see them here, 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 here. So he was damaging his spinal cord through his tics. We can show the video of him.
I'm a different person.
So he's one of the few children that we operated on, because I think it's very, you have to be very careful about operating on children, because the natural history is potentially of big improvement. So this is what happens to him. You'll see these movements. So he has these movements which were damaging his spine. So he also had surgery, which helped. So this is really my last slide. It's to remind you that this is a disorder with serious morbidity, at least in the severe cases, that it is a topic that neurologists should be interested in, but that the biological model is not very satisfactory for studying it. It's a complex neuropsychiatric disorder, so that it's no good using the models that we use to study chorea or myoclonus to study tics. You need to be a bit more expansive in your thinking. So this is another patient which I think describes very much what it's like to have Tourette's. This syndrome has devastating effects on attention, mental processing, self-discipline, willpower, and memory. We live the life of a dog in a twilight world of reclusive, unemployed despair. We are unable to focus even on creative pastimes because of difficulties in concentration. Isolated, we cannot be alone because of destructive regeneration. Our social obnoxiousness and offensiveness makes us embarrassed and makes us lepers, you know, like lepers from the Bible, despairing of our broken down lifestyles. Thanks very much. Thank you.
Thank you very much, Professor Liz, for a great lecture. Can I have one question? I want to ask, could the tics transformed from one body region to another? For example, begin in childhood in motor tics like blinking, and then to the neck muscles, and disappear in the muscles of eye. And another one question, could simple tics, simple motor tics transform to the Gilles de la Tourette syndrome?
Okay, so the answer to your first question is that some patients have one tic throughout their whole life, and it never changes. So they might do this, and they never get anything else. It just stays like that. Other children, and this is much more common, I think their tics change. So, and why and how they change is very, very interesting. And some of my patients told me that when they go to Tourette groups, they learn tics from other children, so that it's like an infectious thing. Now, when you do behavioral therapy, sometimes what happens is you can get rid of the eye wink and they get a tic somewhere else. So, you know, you think you're great, you know, I've got rid of the eye tic, and then they start ticking somewhere else. And so it's quite a challenge. And when we were, I don't use botulinus toxin anymore to treat tics. We used to use botulinus toxin, and some people still do. But sometimes when we injected for an eye blink with botulinus toxin, we cured the eye tic, but they got a tic somewhere else. So, you know, this is something that I think we don't really understand very well, but the tics can certainly move around. They can certainly move. Right, that was your second question. So, yeah, I mean, you know, everything begins with one tic. Patients who present with a vocal tic are more likely to go on to get Gilles de la Tourette syndrome. But remember, Gilles de la Tourette syndrome can be just 2 tics. So you can have a wink and a ooh. That's Gilles de la Tourette syndrome, not like the videos I showed you. So it's, and yet you can have 20 severe motor tics all over the body, and this is not Gilles de la Tourette syndrome. So, you know, the definition is a doctor-generated distinction. So maybe from a concept, it's better for us all to just think about tics, you know, tic disorders, and not make the distinction. But the problem, of course, now is that society has recognized Tourette syndrome. So I'm sure it's the same in Ukraine. If I go down the street now and ask people in England, what is Tourette syndrome? All the young people know what it is. 30 years ago, nobody knew what it was. So it's become a label. Yeah.
Thank you. Yeah. Thank you so much for a really good talk. May I ask you about really interesting, what do you think about association between chronic streptococcal infection and I'm talking about Pantas disease and Tourette syndrome? How often do you see these children with this kind of stuff? And should we check regularly or ask at least patients about chronic streptococcal infection? And should we treat, or if we can treat this?
Yeah. I mean, as you know, neuroimmunology is revolutionizing neuropsychiatry with anti-GAD antibodies being responsible for some patients with acute psychosis. And I think one of the most exciting developments in neurology in the last 10 years has been neuroimmunology. I mean, it's an incredibly important field. But I don't think pandas is an important thing at all. I mean, we tried many years ago we did anti-streptolysin titers on all our patients. We very rarely found elevated titers. We did anti-basal ganglia antibodies, but we found so many false positives in controls that we really couldn't. So, and some of my colleagues tried plasmapheresis for some patients that they thought might have an immunological cause without much sustained success. So I'm not a pandas enthusiast, and although I'm not at the front of tic research anymore, as I told you, I haven't lectured on it for 5 years. My understanding is that in the tic authorities, pandas is dropping. It's less hot news than it was 15 years ago. That doesn't mean it's not important. It might be, but I'm not sure.
Thank you.
Thank you. Thank you very much, Professor, for your coming and for your very interesting lecture. It was great. But I have a very maybe strange question.
They're always the best.
Why your patients in your cases were so severe? Why they didn't have treatment before you have a photo of them? Because they have so destroying problem, so severe, so bad symptoms, so they had to be treated before. I'm sorry for your question, but
it's a very good question.
It was very strange for me because I thought that if their doctors saw their depression, their social problems, they had to prescribe them neuroleptics.
Okay, so first of all, you probably noticed it's quite an old film. Some of those videos are from when I wrote the book. And I think if I talk to my colleagues now, they don't see so many patients like this. But of course, these are I am showing you the most extreme cases. This is not representative of Tourette syndrome, but I'm showing you those because maybe we can learn through these strange behaviors that they have something about the mechanisms for tic and Tourette syndrome. But I should say that all of these patients had treatment, and it was unsuccessful. So don't be so optimistic about treatment. I mean, these are patients, at least the video of the very severe ones, these are of course the sort of patients that you might now consider for surgery, because behavioral therapy didn't help them, and neuroleptics didn't help them. They stopped taking neuroleptics because it didn't help them at all. It made them worse. So, but the ones I'm showing you is like the most severe cases. So these are very rare to see these patients. But I'm sure you can see a few in Ukraine like that. But why? Of course, one question is why are they so severe? And why are the others not so severe? I don't know, but it's important, yeah.
I ask in Russia.
Okay.
Okay. Профессор Лис, почему, как вы думаете, когда один человек начинает зевать, то по всему залу проходит пароксизм зевоты? Когда один человек начинает кашлять, то по всему залу начинают кашлять. Когда один начинает аплодировать, то по всему залу начинают аплодировать. А почему икота так не распространяется? Разные механизмы, и это имеет отношение к механизму тиков?
I think we can learn. I think we can learn from those things. So, yeah, it's interesting. I mean, hiccup is a normal involuntary movement, but so is yawning. But they must be different. But how are they different is the thing. But you're right. I mean. The fact that the patients copy tics from other patients suggests a similarity with yawning, yeah, for example. So I don't know, but I think we can learn from that that thing. And also, of course, you can suppress a yawn. And do you think sneezes are infectious? No. So sneeze is like hiccup. I mean, if I sneeze, you won't start sneezing, no? Maybe you will. But if I yawn, maybe you will. But
yes.
So it's they're different.
Okay.
Yeah.
Okay. Okay. Last question. Are there cultural differences in tics, in simple tics? in Japan, in Germany, in maybe in the United States.
Yeah, I think maybe there is, but I think the motor tics are quite similar in all countries. And this might be because this is a sort of primitive method of communication, non-verbal communication, which is for all human beings. But as you know, copro phenomena are exceptionally rare in Japan, because if you make an insult, you have to kill yourself, you know, to a harakiri. If you so you in the Japanese studies you see very little copromimia, and of course the content of the coprolalia differs in different countries. So generally the patients with Tourette syndrome use the strongest copro phenomena. So there's a hierarchy of copro phenomena. So in Spain, for example, religious blasphemy is the top or high. So they use more this. In England, it's less. So the copro phenomena in England is related to sexual derogatory comments about sexual things. But it's delivered in a very aggressive way, like fuck, 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 not fuck, you know. So it's the intonation is quite important, I think.
Thank you, thank you.
Скажите, пожалуйста, есть ли данные о наследственности в вопросах Жиль-де-Ля-Туретта?
There's massive data. People have been trying to confirm that this disorder is genetic, and most people think it is genetic, but like many psychiatric or neuropsychiatric disorders, it's proved very, very difficult to isolate candidate genes. So identical twin studies, family studies, or everything suggests that there is a strong hereditary component to tics, but still we don't have the genes. So we have to keep working with modern genetic techniques, polygenic methods and so on to try to find it. That's, yeah.
Dear Professor Liss, I think, I'm sure that we will keep this day in our memory for a long time, and we'll be waiting for your next arrival to Kiev. Thank you very much.
Thank you so much.
Thank you.